I'll see you next year for my flu shot.
Bree, before you leave. Hi, Dr. Lewis. Good to see you.
Hi.
Looking over your chart here,
Yeah.
I notice you're 30.
Yes.
You have a cervix, is that correct?
I think so.
What we like to do is we like to screen for cervical cancer. We do that by a pap smear. It's recommended by the USPSTF, bunch of words there, to screen for precancerous lesions. And actually the goal is to identify those precancerous lesions to prevent development of cervical cancer. So if you feel comfortable with me taking care of that, the procedure is pretty easy. We kind of go in there with a speculum, open it up, scrape a little bit off the side, some mucus and cells, pop it in a lab test tube, come back in a week, and it's pretty cut and dry.
Is there any way you could help me with that?
Dr. Alex, do you think you might want to wash your hands?
Yeah, sure. That's good. Yeah. You want her to do it? All right, I'll cool that. Bree, I'm glad you decided to do this today. I think it's real beneficial for you.
It's getting a little cold.
Okay.
Oh, okay. You need a chip before you get started? So
Are you supposed to?
USPS, yeah, just relax. The USPSTF recommends that for women ages 21 to 65 that you do this screening every 3 years.
Okay.
Women ages 30 to 65, that would be you, you're 30 years old. You can actually combine this with an HPV testing and do it every 5 years, so less frequent. Does that sound good to you?
Yeah, let's do that.
Okay. So just so you know, the estimated new cases of cervical cancer in the United States in 2010 were 12,000, of which 4,200 deaths occurred.
Well, that's
so this
pretty scary.
It's pretty scary, so it's a good thing you're doing this today.
Yeah.
Most cases of cervical cancer occurred in women who have not been appropriately screened. Strategies that aim to ensure that all women are screened at the appropriate interval and receive adequate follow-up are most likely to be successful in further reducing cervical cancer incidence.
Okay.
Screening with cervical cytology, which is the pap smear, which we're going to go ahead and do today. Or testing for multiple oncogenic HPV types, which we're also going to do today, can lead to detection in those high-grade precancerous lesions, and then we can go from there.
Okay.
Do you have any questions?
No. Are we done yet?
No, she probably needs another chip.
Hey girl, what's up?
Not much. Having a beer in the middle of a Tuesday?
Whatever, it's really nice outside.
It is really nice.
What have you been up to?
Well, I just got my pap smear.
Oh, yeah?
Yeah.
How'd that go?
It's not my favorite thing in the world, but I was a little nervous and my doctor creeped me out a little bit, but my nurse was totally cool. She made me feel really comfortable. It really wasn't that bad. I'm definitely going to go back to her when I'm due in 3 years.
Yeah, I don't know about all that. It just kind of creeps me out, like the thought of having somebody down in there.
Yeah.
Ugh.
I know what you mean. I thought the same thing, but it really wasn't as bad as I thought it'd be.
Plus, I don't have insurance. I don't even know where to go. I don't know.
Well, there's a lot of free clinics you can go to if you don't have insurance, or even if your income isn't enough to cover the procedures that will be totally free for you. I know Planned Parenthood does it for free. Since we live in California, there's some state-subsidized programs that will pay for virtually the entire service. You should check it out.
Yeah, maybe.
Plus, how old are you?
I'm 25.
Okay, so as long as you're before age 26, they have an HPV vaccine that covers the 2 types that are most responsible for cervical cancer, HPV 16 and 18. It covers about 70% of the cases of cervical cancer. You should definitely get it. It's 3 shots administered over 6 months, and I bet you could get insurance to cover it, or one of these free clinics might have a program.
Yeah, I don't know. I'm not really that worried about it.
Clearly.
Pardon me, ladies. I couldn't help but overhear that you're nervous about getting screened for cervical cancer. Let me tell you about some of the reasons why you shouldn't be afraid and why it's important to get screened.
All right.
The first barrier we can think about is language. If you don't speak English and you live in this country, it might be difficult for you to identify when, how, and where you should get screened, because you may not be able to receive education from any practitioners or read any of the health literature. Another barrier is ethnicity. Black women actually have the highest death rate from cervical cancer. Another barrier would be education level. According to the CDC, the likelihood of getting screened if you have no high school diploma or GED is only 60%. However, if you have some college or more, the likelihood of getting screened is 82.6%. Another barrier would be socioeconomic status. Women with a personal income of $20,000 a year were 2.4 times more likely to have never been screened for cervical cancer than women who made $60,000 a year. Other barriers to cervical cancer screening would be immigration status. Immigrants have been found to have much lower levels of screening for cervical cancer done, especially Asian women. As far as access to healthcare, insurance coverage would severely limit your ability to get screened for cervical cancer in specific areas. Some risks of the screening procedure: if you get a false positive, there can be psychological stress associated with that, as well as maybe a stigma. And other risks would be if you do have treatment done of the precancerous lesions, it's often excisional treatment, and sometimes that can cause bleeding, discharge, and it can also affect pregnancies later in life. Some limitations that have been found by the USPSTF are that there is a lack of long-term cumulative data from screening trials on cervical cancer. There are additional data needed to determine the long-term benefits and harms of screening. There's also limited evidence of the benefits and harms of using HPV testing alone as a screening strategy. Right now they recommend it with a pap smear.
Hey ladies, even though gynecology is just a hobby of mine, I do have some things I'd like to talk to you about the importance of adherence to screening guidelines.
Okay.
Much of the available information show that the largest health disparities were between some ethnicities, most noticeably Asians, Native Americans on the low end, and then African Americans and whites on the high end. Other studies point to some other factors that influence the prevalence of cervical cancer screenings. Those include more access to healthcare means more screenings. Younger women and smokers have less screenings. Current smokers, obese women, and a substantial degree of psychological distress, they all have lower screenings. HIV positive women, and especially those that smoke, they also have lower screenings as well. Many immigrants, two that I found, Latinas and Somalis, they have especially low instances of cancer screenings, cervical cancer screenings. So the recommendation is high coverage needs to be given to high risk populations. And some of those that we found include HPV infection, smokers, which we've discussed, the immunosuppressed, chlamydia infections, diet, especially poor diets, high in fat and low in vegetables and fruits, those that use oral contraceptives, intrauterine devices, multiple full-term pregnancies, and young ages at first pregnancies, poverty, and also a family history of cervical cancer.
Alright, so we have a couple things we need to address. Guidelines have changed for cervical cancer screening, and yet screening rates are actually going down, and we need to address that at this hospital. So I think that we should look at the health belief model. Alex, why don't you talk a little bit about what a CNL can do to address those?
We can address perceived susceptibility by ensuring that every patient that comes in to our clinic will understand that HPV and cervical cancer are actually linked. In order to address perceived severity, we need to let them know that screening can actually prevent cancer, and that cancer can usually result in either surgery or worse, death. For perceived benefits, I think we need to offer some evidence that screening actually does help find precancerous lesions, and there's less invasive treatment that can help prevent cancer. For perceived costs, we'd let them know every 3 years is pretty infrequent for a quick screening that pretty much every doctor can do. For motivation, we need to re-emphasize the severity of potential complications from not doing the screening. And for enabling factors, we need to ensure that patients like their personal doctor, it's close by, quick results, and we need to address a lot of these financial concerns that they may have.
We should discuss some effective strategies that a CNL can use to influence the healthcare system. Well, basically our main priority is educating the public about this issue. So perhaps some school visits or meeting with educators to make sure that a curriculum addresses this issue could be of assistance. ensuring that young girls receive the HPV vaccines and that the families are okay with it and understand the reason for it. Cost can be a big issue for many people, especially because if there are regular results, colposcopy can follow, cytology adds up, and even surgical procedures are very expensive. And so we need to address this, speak to women and their families about resources if their insurance doesn't cover it. We need to explain everything to patients very clearly, avoiding medical jargon as much as possible. Perhaps an email or like a mail reminder to women when they're due for their pap smears could be of help. So free health clinics are a great resource. It's important to make sure that families understand the importance of screening, because mothers really do play a big part in their daughter's sexual beliefs, practices, or health literacy. Finally, I think we should address some social, environmental, and health policy implications of the current screening recommendations. Most women probably don't realize the high incidence of cancer. According to the CDC, almost every single person who is sexually active will acquire a form of HPV in their lifetime. So it's important to address this fact. Of the sexually active female population, 13% of sexually active young women develop low-grade squamous epithelial lesions. So I think some policy implications of this. We need to be aware of the barriers that women face. Making the HPV vaccine mandatory was a good step in the right direction. Health literacy can be expanded by explaining the reason for this vaccine at the time they get it to young women. Literacy could be expanded by maybe instituting a special part of the sex education that high schoolers receive. We also need to make sure that primary care physicians and nurse practitioners are talking to all their patients about their reproductive health at every appointment to make sure it's addressed, which follows along with our health belief model and perceived susceptibility and severity. So I think that's where we should take this and move forward and institute change as CNLs. So.